Welcome to the Functional Neurologic Disorders Society podcast. I'm your host, Erica Cotton, coming to you from Chicago, Illinois, with a special thanks to Michael Romeo, our production engineer, coming to us from Australia, and our content curator, Ingrid Hertzauer, from the UK. My guest this week is Dr. Erin Fobian. She is an associate professor and clinical researcher at the University of Alabama at Birmingham, where she is the PI for a functional neurologic disorder and pediatric behavioral health laboratory. In this episode, Dr. Fobian and I discuss her background and pathway into FND, the similarities and divergences in FND between pediatric and adult populations, her important and pioneering work in pediatric FND treatment development, namely the ReACT trials, as well as exciting new developments to increase access to these treatment services, and novel approaches for standardized training for behavioral health professionals in pediatric FND. I've really enjoyed this conversation, getting me out of the adult FND world and seeing such pioneering work, which we can all hopefully learn from. So here's my conversation with Dr. Erin Fobian. Thank you so much, Erin, for joining me today. It's wonderful to be able to talk with you about such an important topic. But before we get started and diving in, we'd love to hear about your academic background, how you arrived at including FND in your work, and kind of the career path you've taken, and so on.
Yeah, thank you so much for having me. I'm really excited to talk to you today. So I am a clinical psychologist, and during graduate school is when I saw my first adolescent with FND, and she had just been diagnosed with functional seizures in the EMU, the Children's Hospital, and we went to their hospital room and met with her family and with her. And I remember basically only telling them that FND was real, her symptoms are real, and that she should go back to school. And so I remember walking out of that room and feeling frustrated and just really sad that we weren't able to offer them some kind of treatment to help with their symptoms, because their primary concern was clearly, what are we going to do? She's still having seizures. What are we supposed to do to help with the seizures? And we really didn't have an answer to that. And so about a year later, it was actually the night before my interview for internship at Texas Children's Hospital, a talk show came on the TV in the hotel there was a group of adolescents that had been diagnosed with functional tics in the Northeast several years ago. And my mom had come with me on this because we were going to spend several days in Seattle after interviews were over, just vacationing. And she asked me about it. She's like, this seems really interesting. What is that? And I told her, I'm not sure exactly. I'd seen one patient with symptoms like that. I knew that they weren't faking and that they were real, but that just seems sort of like fate, because I matched at Texas Children's Hospital and we ended up seeing lots of adolescents with FND while I was on internship. And it was there where they taught me that we should help them learn to control their symptoms. And, this is really where the core piece of retraining and control therapy that I later developed was really initially conceived, the plan of, using habit reversal to help them be able to prevent or interrupt their symptoms. And their symptoms would often respond so quickly. Yeah,
I saw in one of your papers, it was like 4.9 sessions or something, like hovering right around 5 sessions, which is quite impressive.
And that's where it would get to 0. I mean, often after one session, their symptoms will at least change. And so, it was like, this is great. Like most things nearly we treat, it doesn't respond that well or that fast anyway. And, the families and children are so debilitated and so distressed, and their lives have just been turned upside down. And so being able to offer them a treatment that could help them get back to their daily lives, I just almost immediately knew that this is what I wanted to do, from now on. I just wanted to treat this and help these patients. So that's how I got into FND. I went on to postdoc and started further outlining the treatment and went from there.
Awesome. And you're now 80% research and 20% clinical, so more on the research development, treatment development, and disbursement side of things.
Yes. And so all of it's clinical research. So we're doing We have 2 NIH-funded clinical trials now, so even the research is still very patient heavy.
Yeah, that's so it's not even translational, it's direct clinical research, which is so needed. Wonderful. Before we get into talking about your ReACT trial and important upcoming announcements about next steps from the ReACT trial, I just wanted to touch base for our listeners to provide a basic orientation around sort of how we conceptualize FND in children and how similar or different that is to the adult world. And listeners have known I'm the adult person, so I come from the lens of I know the adults and the peds are they little humans? Are they different humans? What's the relevance, especially when it comes to FND, and how much does things like the biopsychosocial model, alexithymia, or agency and control, all those kind of things that we consider in the adult world, how relevant is that to kids? And what do you think? Just more briefly on that as an introduction for our listeners.
Yeah, so, I think overall, probably the main ideological mechanisms which underlie FND in adults underlie that in kids. With the predictive coding models, I think, it really allows for that heterogeneity in their previous experiences. So, what the specific experiences they have, could probably differ, but I think really still fit in the predictive coding models. The main difference, so we compared children with functional seizures to match controls based on age, race, sex, and family income. And we looked at the MACI, so it's like maladaptive personality traits.
Mm-hmm.
We looked at the BAS-2, which looks at symptoms of internalizing and externalizing disorders. And we looked at the childhood trauma questionnaire. And the only thing that was significantly different between the kids with functional seizures and the match controls was somatization.
Mm-hmm.
So other physical complaints like pain. So that doesn't mean that these patients didn't have anxiety or depression. The T-scores for anxiety and depression were really high for both groups.
Mm-hmm.
So that's there. I think, what that says is just that, psychiatric comorbidities, personality traits, trauma are not unique to FND and probably not the thing that we should target to improve it directly. I think it can absolutely be a risk factor and a contributing factor, and probably an exacerbating or maintaining factor. I think the biggest difference, though, between the adult literature and the child literature is some of the psychiatric comorbidities, but also the trauma.
Yeah.
Not even just in this study, but in other studies of children, it's been pretty consistently found that there aren't greater reports of abuse, especially sexual abuse. And so I think that that's just different from the adult literature.
That is a marked difference, given the base rates of trauma being so much higher in the adult populations with FND. That's an interesting difference, and it does speak potentially more to that primary somatization mechanism of kids who develop FND specifically.
Mm-hmm. And they still have the higher rates of comorbid neurological symptoms. I think it's 20 to 30% of the kids with functional seizures have comorbid epilepsy. Mm-hmm. I don't know the numbers. We haven't looked at it, but even more have had a seizure in their history, not necessarily having comorbid epilepsy now, but having had like a febrile seizure when they were younger, or having had epilepsy that resolved, a lot of times pediatric epilepsy can resolve over time. And so they have similar comorbidities in terms of physical risk factors. And so the biopsychosocial model really fits well with kids as well. The neurological assessment is really important. Working with PT, OT, and speech is really important on the biological side. Knowing that there could be comorbidities of psychiatric disorders is important. So making sure that we're able to assess them well for any kind of comorbidity and make sure that we do provide treatment for that. The having FND in general is just distressing. And so being able to help them manage, an illness that's probably been chronic for them often for some time. And they're often not in school. Their parents aren't working. A lot of them have taken off and had to stay home. And so there's financial stress. There's, stress being behind in schoolwork and not being able to do activities and isolation from friends. And so helping them be able to get back to all of those activities is really important as well.
Do you see as many comorbidities related to like pain or sleep disorders, like primary insomnia, sleep impairment, comorbid pain conditions, as we normally do in the adult literature?
So pain definitely overlaps, it's a pretty common comorbidity with FND.
Headache pain, fibromyalgia like in adults, GI pain, I'd imagine more for kids, a little generalized pain.
Yeah. So, GI pain, migraines, like even chronic daily headache, and sometimes just like generalized pain, just like sometimes they call it amps, but it's like, pain in their legs or pain in their back, things like that.
What about fatigue and sleep? Are they prone to insomnia? Are the little ones more prone to insomnia?
I don't know. I don't know the answer to that. So we are actually we're using actigraphy to assess sleep before and then after treatment. So I think we'll be able to know that. However, we have looked a little bit. So we've peaked with about half of the sample that we want. And so what we thought was that they were going to be sleeping less, but actually they're sleeping more. I think because they're so disabled, they're not able to go and go to school. I think they're laying in bed and their sleep has increased. And we started looking at BMI percentile in children as well, and that improves after treatment. Again, this is all like we're looking at effect sizes. So, this is like preliminary, just watching that. So I think too that they're probably more sedentary than normal. I think that they're sleeping more than normal because I think FND makes them fatigued. The symptoms make them more fatigued, and I think they're sleeping more at that point. And with treatment, they're able to return to activities, and so their sleep returns more to normal adolescent sleep.
Normal sleep and behavioral
at that point.
Yeah.
Probably not getting enough sleep like most adolescents at that point. But
oh, wonderful. Yeah, that's a super interesting distinction. You hear, in a lot of adult cases that there's insomnia or trouble falling asleep or staying asleep and disrupted sleep. And then general daytime fatigue on top of that, but not some cases you hear more extreme fatigue where they're just sleeping all the time. But insomnia, I think, is maybe more prevalent in adults as an adult manifestation. But it's really interesting to note some of these differences that are really relevant. I mean, it's still something relevant to address. It's just, it might be in a different direction or a different way when it comes to peds. Wonderful. Well, thank you for the basics. So in summary, if I can summarize it for our listeners, it sounds like the biopsychosocial model still highly relevant, considering all the comorbid factors, still highly relevant, potentially the unique role of psychiatric comorbidities or even trauma might be less of a driving factor for pediatrics, but more of a primary somatization tendency that then becomes the focus, which is a great transition then to talking about your ReACT trial and importantly, upcoming next steps, which by the time this podcast is out will be fully announced to the world. So we're technically announcing it first here, but given production delays, will be later to the game. But you can find links to everything we're announcing today along with the podcast posting. So why don't you tell us a bit about that?
Yeah, so when I was hired as faculty, I was hired to do sleep and obesity research. And I told them when I was hired, I was like, so I have this other thing and I'm interested. I have this other treatment and I'd love to do research on it. And they were like, I don't know if you can get that funded, but you can do that in your clinical time. I was like, great, sold. Okay. So I was able.
Bless you for doing that. It's just getting it through.
It's actually, just in general for people out there wanting to do research, it was a great way to get things approved and running without actually having funding.
Mm-hmm.
So, I was seeing these adolescents in my clinic. And so we did the randomized control trial in clinic, and were, able to get the results and publish them in 2020. So I think we had, almost 30 total that were randomized to ReACT or to supportive therapy. And, we only did eight sessions of treatment for that study. Our new studies are all doing 12, but for that, at the end of treatment, all of our patients were at 0 episodes for the week after treatment. And then for the 60 days after, all of our patients in ReACT were at 0. And our kiddos in the supportive therapy were still about the same. Their functional seizure frequency hadn't changed. And so at that point, we allowed participants to switch over out of supportive.
Mm-hmm.
So we don't have longer term follow-up for the supportive group. But the individuals in ReACT had, I think 82% continued to have no functional seizures for at least 60 days. And then at our 1-year follow-up, it's like 57%. So we had good outcomes. It was great preliminary data to sort of launch our next steps in the research. So we have an NIMH trial that's ongoing right now, an R61, R33, that's looking at the mechanisms by which treatment are effective, and really focusing on sense of control or sense of agency. So that was another thing that we looked at and compared our kids with functional seizures to our matched controls. And we found that they have poorer awareness that their control is being manipulated on a sense of control task. So it suggests, consistent with imaging studies in both adult and kids, that their sense of control is different and possibly a good target. We also have some preliminary data looking at pre and post from that significantly improves after treatment, and that change is correlated with their change in functional seizures. So we're hopeful that maybe that is a direct mechanism that we can target and change. We know in other neurobiological research that the sense of control is related to it can be increased by using efferent motor control. So being able to give, individuals that ability to do physical movements that prevent
voluntary,
or
deliberate physical movement.
So theoretically, all of that should increase that sense of control and be what we're trying to target. So, that's all ongoing. We have good preliminary data to support that, but still looking.
Yeah. One
Yeah.
point of clarification just for our listeners, specifically in the ReACT trial and talking about control and linking it back to the prior sort of core mechanism of somatization. Are you meaning control over symptoms that are a precursor to the functional seizure episodes, during the functional seizure episodes, or are there additional things? I think in other papers you mentioned sort of habit reversal even before functional seizures happen. So what are you targeting for control? Behaviors, physical sensations, reactions to physical sensations, all of the above, the whole trifecta for somatization?
Yeah. So it's a good question. So the core pieces that we start with in ReACT, we explain sort of like I explained earlier of, this is your body has learned a new way to respond to things in your environment, and we're going to help you retrain that. So you don't have control right now, but we're going to help you retrain that control. And so then what we do, we go ahead and target like their automatic thoughts when symptoms begin or when they know they're about to begin. And so we know generally that's a scared thought, like an, oh no, this is bad. And then an expectation, like here it comes, this is about to start. And so we just go ahead, instead of walking through the CBT process like we normally do, like identifying thoughts and helping them challenge them, we just sort of give them rational responses.
Substitute. You give them a direct substitute thought.
here you go. We're
Yep.
just going to do this right now. So
Think
you
this,
leave here
not
today.
that.
And yeah. And we do, it's like, okay, so we have a calm thought, right? It's not going to hurt me. It's not going to harm me is the right way. Probably it may hurt, but it's not going to harm me long-term. How do you know that? You've had a lot of these now, and you haven't been harmed long-term. You've been to a lot of doctors and that told you, they told you that this isn't going to harm you. So you have evidence to know now that this is true. And then a control thought. So this is countering the expectation, so it's like, okay, I have a plan. I know what to do. I don't have to have an episode.
Yep.
I can learn to control this.
I've got this. If it happens, I can manage it. If it doesn't happen, I can manage it. It's all going to be okay.
Exactly.
Yeah.
Yeah. And so then that goes into like the habit reversal pieces for the symptoms. So in one of our studies, we found that 98% of our patients had premonitory symptoms that indicated the functional seizures were going to start at least some of the time, maybe not every time, but some of the time they did. And so what we have them do is as soon as they know it's coming or as soon as symptoms do start, they sit, they do the thoughts, and we give them specific opposing responses for each of their symptoms. So, for loss of consciousness, we may have them focus on things, talk out loud, move their hands, move their head.
Activating, grounding kind of things.
Shaking, we have them do big physical movements, really using principles of like the bigger the better, the sooner the better. And
activate a totally different network and pathway and make that the voluntary response rather than the unwanted involuntary response.
Yeah, make it really hard for that involuntary one to be able to begin. Or if it has begun, go ahead and do the other response to counter that so that you can take back control and prevent that involuntary response from continuing. And so, I think it's important too. We don't use suppression. It's not like don't move, like suppress it. It's, we give you an active plan to be able to either keep control before the involuntary symptoms begin or to regain control once they have begun. And so, and then we
do you have any role for like relaxation? And a lot of the adult literature focuses on mindfulness, body scans, maintaining relaxation and sort of symptom prevention, as well as maintaining calm once symptoms do start. Is that playing a role in your treatment?
So the thought piece, I think, is the goal to keep them calm. So, like tell yourself it's okay, that you're going to be able to control, but with the opposing responses we give them, they're probably not relaxed. And, we want them to do the opposing responses once the symptoms begin to, and, that can make their muscles sore, right? They're actively working to regain control of a movement that's already happening. So I would say, they're probably not relaxed at that moment. We really want them to be very active and moving to be able to prevent that involuntary symptom from being able to take over. And so I think that being active makes that easier than maybe relaxation. That's a theory I have. I have nothing that proves that, but that's sort of the idea behind using the habit reversal. We do have them breathe. The very last step of the plan is breathe, and we don't go into that very much unless they have a really specific breathing symptom that we want to, give them a very specific opposing response to. But the idea is like, just make sure you're breathing, right? Stay calm, make sure you're breathing, tell yourself you're calm and control thoughts, and that's going to help you be able to implement the opposing response plan for the symptoms.
Yep, to engage in the behaviors and the alternative physical actions. Yeah. What role does environmental modification, stressor modification, communication modification take? It's generally pretty big in most of the adult treatments, but I imagine it's different for kids and their families and school. There's only so much you can modify or do. How much or little does that play in your treatment or not?
Yeah. So we try to send them back to everything. We want them to, as soon as we can, get them back to their other activities, because sometimes we can identify triggers, and a lot of times you just can't identify all the triggers for this. And so if we put them back into daily life, they're going to encounter those triggers, and we want them to encounter the triggers so that they can do their plan and retrain that situation or emotion or,
that learned set of association
change in the body.
Yeah.
That whatever it is that's triggering it, it can be retrained as a trigger because they're then, taking control. And so, we tell them to, sometimes patients will say that stress or anxiety can be a trigger. And so what we tell them is that, we want them to be able to be stressed or to have anxiety and not have symptoms.
Mm-hmm.
So what we're going to do is not avoid things that are stressors and not avoid things that, cause anxiety, because we want them to be able to do that plan and retrain those as triggers. Just because patients that have a really strong anxiety disorder will probably, struggle with that on and off through life. And we definitely don't want that to be paired continuously with the FND for them. If we can take that away as a trigger, I think that's really, it's really helpful, obviously. Same thing with stress. You're just going to be stressed,
Mm-hmm. Be stressed, but don't have symptoms.
Yeah. They're going to have exams. They're going to go to college, maybe, they're going to have arguments with friends and family and whatever. And we want to make sure that they can just sort of live life and all those emotions without having the FND as a trigger. So we do, unintentionally send them back to everything so that, any trigger that's there can be triggered, but also if we know that there are specific things that may trigger it, we may do specific exposures to help them be able to manage those situations or whatever it is so that that doesn't become a trigger for them anymore.
Wonderful. So to summarize, if I'm hearing correctly, it's really focused on body symptom management and taking control of those body symptoms and then decoupling those responses by putting that child back in their daily life to face those circumstances so that they can practice the skills that they're learning to decouple and maintain control over their body in those situations. Learn to have stress, anxiety symptoms, or stress and anxiety, or stress and anxiety without having symptoms. That sounds right.
Yeah. And I didn't exactly answer your environmental question, which I think is important with patients. So with children, especially. So for the parents, the parents get a plan too. And basically it is make sure that they're safe, make sure your child is safe. And as long as they're safe, stand behind them, monitor them, and let them do their plan. And we reinforce how incredibly difficult this is for families to do. This is not a typical parent response. It shouldn't be until you know what
instinct.
You've been told that, right? It's just, it should not be your automatic response, But the reason why we do that is we know that when we're talking about retraining something that is a reflex, something that is involuntary, we know that if they'll need someone or something external to themselves to stop it or prevent it, they'll always need that thing. Right. But once we can empower themselves to be able to stop or prevent it, that's when it can actually retrain and the frequency that it's triggered can decrease. And so we just really empathize with the parents and just make sure their kid is safe. But this is going to help,
Yeah.
In school, same thing. We want to get them, if we can, outside of the view of peers. So they're not having to sit in front of peers and do a plan and have episodes. So if we can get them out of the room, if they know it's coming, that's great. And then same thing to the school, just monitor, make sure they're safe, and then let them manage, and then go back to class, go back to what you're doing. Don't let it interrupt whatever you were doing that day.
Yeah. Don't allow the behavioral avoidance or maladaptive coping to sink in. Just get back on the horse, so to speak.
Definitely.
Wonderful. Well, I'm very excited to hear about the next stage to all this wonderful work that you've already done. And it sounds like there's an exciting new phase that's available. If you'd like to tell our listeners about that.
Yes. So, okay, there are two phases. One is that we are continuing research on it. I told you already about the mechanistic study that we're doing. We also have an R01 with NCCIH to be able to do a multi-site efficacy. So we're doing a multi-site feasibility trial for the future efficacy trial. So basically, I'm able to train the other sites and show that we can all recruit and do ReACT with fidelity. And then next step will be that large scale efficacy trial. So that's exciting because just in FND research in general, we need efficacy trials with large sample sizes.
Congratulations. That's so wonderful.
Thank you. We're very excited getting that started right now. And then the second phase, the availability of treatment for individuals is really, it's just very sparse. There aren't a lot of good treatment options. And we have patients traveling from all over the country often to come to Birmingham for treatment. And some people can do that and some people just feasibly can't. So trying to be able to expand access to care, we worked with UAB to establish ReACT FND Health, which is going to have as its mission to expand access to FND-informed treatment. And so we'll do that through two ways. And one of the ways will be that we'll be offering direct patient treatment, direct access to ReACT via telehealth. So it will be available to anyone who is in a PsyPact state. So PsyPact is a reciprocity agreement in the U.S. that allows if you have a license in one state that has PsyPact legislation approved in your state, you can practice telepsychology, telehealth in any of the other PsyPact states. And so there are about almost 40 states now that are PsyPact states, and it grows all the time. So the goal of this is really to be able to expand access to individuals across the U.S.
So that would mean that your providers and your provider group would be able to provide care to people if they're in a PsyPact state. So then you'd have access, these patients in the 40 other states would have access to you and your treatment team for this treatment.
Yes, it won't be myself providing the treatment. It will be people that I train and we'll be meeting with them regularly too, just for case consultations and things as well. But yes,
huge.
Yeah, it's really exciting. The second phase of that, so we're hopeful that we'll begin being able to start treating patients directly by summer. That is our goal.
Wow.
But this is just so new and so different than anything we've ever done. So who knows? But that is our goal.
That's such a wonderful undertaking, though. It could just increase access for so many people. I mean, access to good quality FND care with a provider who has some training in it is just very hard to come by in the adult world and the pediatric world, it seems. And you're really going to put a dent in that, which is amazing.
And being able to offer it to people who are in rural areas too. You don't even have to be near a big city. It can be. So it's exciting.
Very.
And then phase 2 is going to be that we're going to actually train other therapists, other providers in ReACT so that they're able to use ReACT in their practice. And so, that will expand care in the US and then hopefully throughout, lots of other countries as well.
That is so wonderful. Training opportunities are also very, very limited for FND, especially specific populations like child versus adult, and in validated treatments that are shown to work. That's so wonderful. When is the training arm looking to be brought online? I know, I'm sorry. I know our listeners are going to be so eager.
I mean, maybe by the end of the year. I hope by the end of I don't know though. No promises.
No pressure, just excitement and enthusiasm, as well as just significant gratitude to your team for putting all this together.
The pressure is probably mostly just coming from me, like wanting to get this out. So, but it's exciting. Yeah, I know just a lot of challenges to do this. I think that we aren't even aware of yet, but we are working diligently to figure them out and start
The good thing is that you're trying, right? I mean, you've established a treatment that works, and then you're taking it to the next level. Okay, now how do we get this in the hands of as many people as possible to have an impact? Which I'm sure back in your meeting your first non-epileptic seizure patient, you didn't think you'd be rolling out a nationwide treatment and training protocol, but thank goodness you are, and you're willing to take that risk and not see it as too much of a challenge or mountain to climb, going, yeah, no, not me. Someone else can do that. You're doing it, which is so brilliant.
It's funny. Yes, this is not ever what I pictured my life or my career to be. I am so thankful for it. I love it. But yeah, you just never know where you'll end up. I could have never imagined this.
But I mean, thank goodness that you're willing to take those risks and put yourself out there and directly fill the gaps, right? You see the gap and you're like, okay, there is a gap. Let's fill it. How do we do that? What's the best way? And needing to kind of have a sense of humility about it, like, well, we're going to try and see what happens.
I have lots of wonderful people around me that are sort of pushing me along the way. It's like I started doing the research on ReACT and people are like, well, I need it. How do we get it? How do we expand it? It's like, oh, I don't know. Come on, let's figure that out. So RT Vasilopoulos is helping me. She's a pediatric psychologist at Yale. She's helping me with ReACT FND Health. And
she's been on a few of your publications I've seen, right? Yeah.
Yes. Mm-hmm. Yeah, she's been great to work with, and she's definitely helping me push me along, and definitely patience, being like, okay, what do you need to do next?
Yeah.
Like people confronting me a lot of like, how are you going to do this next? What's next? It's like, okay, you're right. We should do this. So thankful for that.
Very much so. But I mean, the work that you're doing also just lays such important foundational work for the rest of other FND conditions in other FND populations. I mean, you can think about the same thing applied to persistent perceptual postural dizziness, into specialty adult populations, to specialty pediatric populations. It's just setting up that model and that framework of, look, it's been done. We can do it again, and it can work, and it is feasible, which is just so pioneering, which is great.
Oh, it's exciting. So, I mean, and we are beginning looking. So at UAB, we use ReACT for our adults, actually. Wow. And with, multiple FND presentations, both in adults and kids. But so we're starting to collect data on ReACT in adults.
Like functional seizures, functional movements, all the above.
All of them. Mm-hmm. And that's what we use. The research that I do is focused on functional seizures, and the decision to do that was really because NIH had not funded a lot of functional studies. Mm-hmm. I was told, NIH is not going to fund that. Just do it in your clinical time. But the functional seizures have EEG, and so when you're going in front of the reviewers and they can see like, okay, this is definitely, we can tell for sure that this is functional seizures. I felt like we'd have a better chance of getting funded, knowing, being able to really determine the diagnosis is correct. And so that's why all of the studies are for functional seizures. But we've started, a ton of our adolescents have multiple FND symptoms. And so what we've started doing is measuring those outcomes for all of the symptoms, so that we can start demonstrating outcomes for other FND subtypes with ReACT. I think too, an interesting part of what we've added to, as part of the manual for ReACT, is that we made it adaptive. And so that each session really targets what the patient needs, like what they've been through since their last session. And so the manual itself is called the Precision Treatment Tool, and basically has the therapist ask the patient, like a series of questions, and then based on those questions from the last week, of their experiences from the last week, it gives them the manual of the things that they should really target and do in that session. And so, we're hopeful that, one, that helps providers, psychologists are not trained to deal with medical things and to say, oh, you're having a seizure. That's okay. Don't go to the hospital. And that's so important for us to be able to like feel empowered and comfortable with the disorder and the treatment to be able to do that. And so being able to provide a tool that helps that and like helps them make those clinical decisions that we make all the time in treatment and make them feel comfortable with that. And then 2, as we start disseminating, allowing the treatment to be able to be disseminated with fidelity. One of the biggest issues in behavioral health, mental health treatments is that we do these really controlled studies where the treatment itself is controlled so tightly.
Yes, you do this at this session, this at that session, this at this session. Yeah, which isn't how you do psychotherapy.
No, and when it's disseminated, it doesn't work that way. It doesn't get done that way. It sort of gets changed or sometimes watered down, and they're not getting the treatment that really was the evidence-based treatment. And so being able to have this tool hopefully will help when we disseminate, keep, the fidelity of the treatment as it's disseminated to keep it as effective as it can be.
Yeah, if you're building in the adaptability as part of the piece that you're testing and then disseminating, that's huge, because then you're sort of building in that natural therapeutic response and increasing the likelihood that that therapeutic response is accurate or helpful for that patient population based on all your years of experience and multiple providers doing this. That's so cool and wonderful. That's like taking a clinical trial to a whole new level of clinical trial.
Standardizing the clinical decision-making that we have to make, in sessions, and helping that be then disseminated in a standardized way, I guess.
Yeah. Oh my gosh, that's so wonderful. You are not only advancing the treatments, but advancing the way we're testing these treatments and incorporating them into clinical practice, which is huge. I can't wait to see the result. That's going to be so cool. We will definitely include links to all of those pieces as well, since it's so important.
Thank you.
Well, this has been a wonderful conversation, and I really appreciate having you here. And maybe in another year or 2, we can have you back on and hear updates and next steps and continued trials, tribulations, and wonderful output from all the great work that you're doing.
Yeah, that's great. Thank you so much for having me. I really enjoyed it.
Wonderful. Okay, thanks so much. As a reminder, listening to this podcast gets you access to a 50% discount for new FNDS membership. Use code FNDS004.